Welcome everyone to the June 2nd COVID-19 clinical care rounds on critical care. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 critical care challenges and successes in patient care and operations. Today, our focus is on cytokine storm, frequently discussed in prior rounds. If I'm an intensivist preparing to care for many COVID-19 patients, the clinicians I want to learn from are those clinicians who have the most experience. This is a voluntary public-private collaboration. Thanks to the multiple professional organizations who have collaborated. These are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges in patient care and operations with other clinicians. Thanks to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds. NETEC has webinars that complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Strubinger and his team for the peer-to-peer learning platform we used for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. This Thursday, June 4th, emergency department rounds will be focused on air and ground interfacility transfers. Also, please look for announcements for next week's rounds. We do have next Tuesdays locked in. The topic will be for critical care on next Tuesday, the ugly tail end of COVID-19 acute respiratory distress syndrome. It is self-evident that our nation's medical response challenges are changing every day. We'll continue to work to identify topics for these peer-to-peer learning rounds that are most timely and helpful to clinicians. For the ECHO clinical rounds we've had to date, we continue to have participants from all states and other countries, predominantly physicians, nurses, and EMS clinicians. We apologize in advance that we're not able to answer all the questions we receive. We've picked out major themes from questions received and hope to cover some of those. Dr. Strubinger will now go over some logistics.
Great, thank you, Rick, and thanks to our presenter today and our panelists and to the over 300 attendees who are joining us to participate in today's rounds. I'm going to go over a few logistic issues. Just to remind people, there is a Q&A button in the bottom of the Zoom toolbar. Please share your questions and comments related to the presentation today with us there. If you've got any kind of technical or IT challenges, go ahead and put that in the chat so we can try and help you with that. Rick is also going to be asking a crowdsourcing question, and we'd like you to answer that question in the chat area. This session is being recorded and your attendance is consent to be recorded. Thank you for that. The presentations are linked to the most recent email announcement that went out this morning from Project ECHO and will be on our website, and there will be a link to the recording as well. And we'll share that in the chat later in the session. Also, we are offering CME and continuing professional development credit through the University of New Mexico. We'll share a link with you about 15 minutes from the end of the session in the chat. Also, there's a link in today's email announcement to the CME survey. That's how we get your feedback so we can improve these rounds. And with that, I want to hand the microphone over to Sharon Van Aersdale with NETEC. Sharon.
Yes, thank you so much. Hello, everyone. Sharon Van Aersdale. I'm the Program Director for Emory Serious Communicable Diseases Unit. I'm also the Director of Education for the National Emerging Special Pathogen Education Center. And it has been an absolute pleasure being able to partner with Project ECHO on these clinical rounds and really allow us the ability to do deep dives into some of the topics that do come up on these clinical rounds. So we do have several webinars already planned. We do them on Wednesdays and Fridays. Our upcoming webinar tomorrow is on emergency management, really thinking about resiliency and recovery, if we can call that recovery. And then also one on Friday related to infection control and prevention strategies. So thanks, Bruce, back to you.
Great, thank you, Sharon. And Rosha McCoy with the AAMC is among the panelists. Rosha, do you want to give an update on the clinical guidance repository?
Yes, thank you very much, Bruce. Yes, I just wanted to remind folks of this resource, which is an open access clinical guidance repository. We have over 80 guidance documents from 17 different academic medical centers and specialty organizations. We also have 6 alignment summaries in key topic areas, looking at alignment and agreement in guidance documents between different organizations and academic medical centers. We're constantly updating the site. So we hope it's of use and would love feedback as well. Thank you.
Great, thank you, Rosha. And Rick, back to you with the crowdsourcing question.
Thanks. We've learned a lot using this technique of crowdsourcing clinical pearls. And today's, speaking of cytokine storm, what approach to cytokine storm in your COVID-19 patients has worked the best? What approach to cytokine storm in your COVID-19 patients has worked the best? Love to see the answers. Last time we did anticoagulation, got a lot of great responses, and like to see what happens with this one as well. So with that, let's see. At this juncture, I think I'm gonna be able to introduce our panelists, or they will introduce themselves. If the panelists, Paul, James, and Vikram would like unmute yourselves, I'll go to each of you to introduce yourselves with name, title, and affiliation.
Hi, everybody. This is Vikram Mukherjee. I'm a pulmonary critical care specialist based out of New York City and work at the Bellevue Hospital, where I'm the director of the Bellevue Medical ICU. I also work with Sharon for NETEC, and I'm fortunate to be part of this group as well. Thank you for having me.
Thanks, Vikram. Hey, Paul?
Paul Bittinger. I'm an emergency physician at Mass General Hospital in Boston and the director of the Center for Disaster Medicine.
Thanks. James?
Hi, James Lawler from University of Nebraska Medical Center. I'm an infectious disease physician here, one of the co-directors for our Global Center for Health Security, and also medical co-director of our biocontainment unit.
Thanks. Apparently people like your Zoom background, James. Seeing that. All right, so with that, let me introduce our speaker for today, Dr. Brian Garibaldi, Director for the Johns Hopkins Biocontainment Unit and the co-president, the Society of Bedside Medicine. He is Associate Professor of Medicine and Physiology at Johns Hopkins University School of Medicine. Brian, welcome.
Thank you so much for inviting me to be here today, Rick. I really appreciate it. Hey, everyone. So today what I'd like to do is talk a little bit about cytokine storm and COVID-19 and frame it through the lens of our biocontainment unit experience. So this is a picture of our biocontainment unit at Johns Hopkins. We're one of the 10 federally funded biocontainment units through HHS ASPR. And we were created in 2015 in response to the Ebola outbreak at that time. And here's just, I'm sure you're all familiar with where the regional treatment centers are. And we partner very closely with Sharon and the folks at NETEC on educational initiatives in the state of Maryland and also in Region 3, which is where we're the regional center. You know, when we started the unit 6 years ago now, obviously our first goal was to provide outstanding patient care and to become federally recognized for doing so. But we realized that in order to do that, we needed to create a robust training program, and that included training our own staff, but also partnering through our health department to train local frontline hospitals in collaboration with our unit so that we would have the ability to get patients triaged, identified, and eventually transferred if necessary. Part of that also involved trying to understand how to do that better, you know, to participate in research and innovation. But until COVID-19, we had not activated our unit other than for drills since 2016. And so this is our staff the night of February 29th when we activated for our first COVID-19 PUI. And our unit actually took care of the first several PUIs and the first 11 confirmed cases before we outstripped our capacity in our unit and our sister airborne unit. But after our unit deactivated and collaborated with our ICUs, our team has still been involved in direct frontline patient care, education. We've helped set up all of our 9 different COVID units across the health system. And now we're all involved in clinical research, and I'll share some of that with you today. But I wanted to start out with our first critically ill patient to the biocontainment unit. So he was a 42-year-old male who presented to the ER at one of our sister hospitals with a 4-day history of fever and cough. He had recently gone to Florida a week before with family, where he was very, very active playing basketball, jogging, had no significant past medical history. But on arrival to the ED, he was febrile to 39. He was breathing in the 40s. He was tachycardic. And he initially required a non-rebreather, but very rapidly was intubated. And this is his first chest x-ray that shows diffuse bilateral infiltrates. And he was intubated in the ER and then sent to our biocontainment unit with a high suspicion for COVID-19. And this was back in early March, so it took us 3 days to get the confirmatory test from the CDC. So we treated him as a presumptive case until we had that test positive. But I wanted to highlight a few important aspects of his initial early critical care period. So you can see here that early on, he had these very, very high spiking fevers to well above 40 that happened almost every 12 hours. And every time he had one of these episodes of high fevers, he had this remarkable increase in his respiratory drive. And I'm sure many of you have seen patients in your ICUs where you're using very, very large amounts of sedation to try to keep people, sedated and synchronous with the ventilator during these really incredible respiratory drive periods. These obviously were accompanied by drops in his saturations, lability in his blood pressure, and also lability in his pulse. And so I think we didn't quite recognize it at the time, but this was probably a case of cytokine storm for this particular patient. And as we look at some of his characteristic lab highlights in his first few days in our ICU and our biocontainment unit, his D-dimer is greater than 30, he had an elevated fibrinogen, he had lymphopenia, he had a high CRP, and he had a high IL-6 level. And actually at this time, we were still using a send-out lab for IL-6, so this took about 4 days to come back. We now have an in-house test that comes back within about 6 hours. So he was intubated for 26 days. He ended up being proned at least 4 times. He was found to have a mild reduced EF and a troponin leak. He had a left brachial vein DVT. He ended up developing a ventilator-associated pneumonia. He had a very prolonged stay on our medicine ward with delirium, and he also had a 50-pound weight loss. But thankfully, he recovered. He was discharged, and I spoke to him last week. He actually went for a mild jog and is doing much better. So when we think about how his trajectory looks, if you kind of try to piece together what his course through our biocontainment unit, our ICU, and our regular medicine floors looks like, this is a visualization that we developed with our partners at the School of Public Health. He immediately on arrival was intubated. That's shown here in peach. Then he went on pressors for a brief period of time. Then he remained intubated. He actually was our longest intubated patient. He was intubated for 26 days. This was in the early days when we weren't sure if it was safe to do tracheostomy. He then was extubated to high flow nasal cannula. He moved on to nasal cannula oxygen, finally Roumera, and then to discharge. And we started trying to visualize the trajectory of our patients using this color scale. And so what you see here on the on the x-axis, is days from admission to the hospital. And then on the y-axis, each one of these horizontal lines is a patient and their trajectory through the hospital. So up here, you see a lot of patients who are in dark blue, which is hospitalized but not on oxygen. Then they go on oxygen in light blue, and then they get discharged. The little gray bar here is patients who, at the time we censored this data in early May, were still in the hospital. But the vast majority of people who only require nasal cannula oxygen get discharged from the hospital. Then you have patients who have this severe disease course, which I'll talk about in a moment. And then unfortunately have a number of patients who go on and die. And so far in our cohort, I'm showing you 832 patients. We've now had close to 1,800 patients through the Johns Hopkins Health System. Our mortality is about 13.5% among those with an observed outcome. And again, this is sort of highlighting what it looks like to be a patient who has severe disease. And you can see here that you start out maybe on room air, transition to higher levels of oxygen, then you get intubated, then you maybe develop, in the orange, these are patients who have multi-system organ failure. And then hopefully you transition back down to room air or just little nasal cannula oxygen and then get discharged. But many of these patients have what we would probably term cytokine storm. Some people have also called this a hyperinflammatory syndrome. What I'm showing here is the criteria that we have developed at Hopkins to identify patients who have a possible hyperinflammatory syndrome and to consider whether or not they might benefit from specific treatment or enrollment in a clinical trial. And so in this first column here, we're just focusing on adults here. I think the multi-inflammatory syndrome in children is a little bit different, and we perhaps can talk about that in the discussion section. But we've identified patients who we believe to be at probably higher risk from developing severe disease or perhaps death, including age, race, underlying immunosuppression, underlying comorbidities. In our population in particular, and this is, I think, evolving across the country, patients under the age of 60 are unlikely to die in our group, but as you have an increase in BMI, your risk of developing severe disease starts to skyrocket. So we have a very large number of young adults who have BMIs over 40, and they tend to be the ones who develop severe disease. Then obviously underlying lung disease and kidney disease. And then when you have those patients that you're worried about this hyperinflammatory syndrome, we look to see, do you have progressive hypoxemia? And we define that as requiring at least 4 liters of oxygen to maintain a SAT above 92. And then do you have a sustained respiratory rate above 30? Do you have hypotension, or do you have persistent fever? And in addition to those clinical features, do you have laboratory evidence of being inflamed? And so not every center has the ability to get IL-6 levels quickly, but if you have an IL-6 level, we've chosen a cutoff of greater than 80 picograms per ml, which is, incidentally, that's actually not an incredibly high IL-6 level when you start thinking about some of the cytokine storm that you can see in response to CAR-T therapy and in oncology. But if you don't have an IL-6 level, if you have an elevated D-dimer, a CRP that's elevated, and elevated ferritin, you probably meet the criteria for a hyperinflammatory syndrome. And then the question is, well, how do you treat that? And we'll get into therapies in just a moment. What I want to show here is just highlighting some of these features in patients in our cohort who had mild to moderate disease. These are patients who at most were on nasal cannula oxygen, patients who developed severe disease who are on either high flow, non-invasive, or intubated, and then those who went on to death. And you can see here that respiratory rate is actually a really good predictor of the severity of your illness state. And even at admission, these are vital signs within 24 hours of admission to the hospital. It's a good predictor of where you're going to end up. So an elevated respiratory rate we know is a poor prognostic sign. Patients who develop severe disease on average had a higher temperature. We looked at the SaO2 to FiO2 ratio, and this allows you to look at patients who haven't had an arterial blood gas, but it gives you a sense of how much oxygen they're requiring in order to keep their SATs up. And you can see, the mild to moderate patients have a very high SaO2 to FiO2 ratio. And in fact, most of them are not on oxygen on admission. And then there's a rapid step off in severe disease in those who died. You can see that lymphopenia tends to be more severe in those who died. The D-dimer is more elevated in those who died, but it is higher in those with severe disease. And then IL-6 levels are definitely higher, at least in the patients in which we've recorded them, in those who died. And interestingly, lots of patients, particularly those who died, had evidence of elevated troponin. And we know that evolving cardiac injury is probably a poor prognostic sign in this disease. I just wanted to highlight a couple of the labs that we have found in multivariate models to be predictive of both death as well as severe disease. So it turns out, this is a cumulative incidence plot looking at those who had a D-dimer just greater than 1 milligrams per liter, which is not very elevated. You can see here that their risk of death was much higher than those who had a lower D-dimer level. And then the same is true in respiratory rate. If your respiratory rate is above 20, you're much more likely to die, at least in our cohort. And those are two of the factors that are part of this hyperinflammatory syndrome. So how can we treat it? Well, the short answer is we don't really know, right? I mean, we don't have very many approved therapies right now, or any approved therapies for COVID-19. We know that the ACT-1 trial showed that remdesivir versus placebo decreased the total length of hospital stay. And so we were part of that ACT-1 trial, and now we have moved on to ACT-2, which has remdesivir as the floor for everyone in the trial, and then adding baricitinib or placebo to that baseline of remdesivir. There's also interest in convalescent plasma to perhaps prevent severe disease, but also as a treatment for patients with severe disease. And then we have several other randomized trials that are currently ongoing, looking specifically at therapies that are likely to decrease cytokine storm. So we have one trial looking at the IL-6 inhibitor clazakizumab in patients who have severe COVID-19 infection. We have another trial looking at sarilumab, which is a monoclonal antibody against the IL-6 receptor. And then we also have an alpha-1 adrenergic receptor blocker trial with prazosin to see if, instead of targeting the cytokine storm specifically, can you actually dampen the catecholamine surge that is secondary to that cytokine dysregulation. And so those are three of the trials that we have available currently for patients to enroll at Hopkins. Early on, before we had trials up and running, we did have a lot of off-label use of tocilizumab. And actually the criteria that I showed you earlier were created specifically to guide the use of tocilizumab in patients who might have cytokine storm. And so of those first 832 patients, 5% received tocilizumab, many of whom were actually immunosuppressed and solid organ transplant recipients. We had 6 deaths, 29 patients who had severe disease, and 4 patients who never progressed beyond mild disease. And I show this to highlight that, yes, we have been using off-label therapies outside of the trial, but I think it's really important to recognize that I have no idea how to interpret these results, right? I have no idea if tocilizumab worked because, as I showed you earlier, many patients developed severe disease who didn't die, right? And so we have no idea outside of a clinical trial if these anti-IL-6 therapies will be effective. And so our current process is to screen patients to see if they're eligible for a clinical trial. And if they are, then they get hopefully enrolled in one of those 3 trials that I mentioned. We actually have 6 other trials that are currently enrolling for other therapies as well. And only if you're not eligible for a trial can you then petition to use off-label tocilizumab for patients with perhaps cytokine storm. So I just briefly wanted to mention there's a whole group of biostatisticians and clinical epidemiologists and also clinicians and data scientists who are working on this data, who are responsible for their visualizations that I showed you and some of the predictive modeling that are looking at factors at presentation that predict a poor outcome. I think we're now moving on to trying to do multi-state modeling to really understand where you are today and how that might predict where you are tomorrow. And that hopefully will lead to important information about how do we more appropriately select patients for off-label use of therapies for enrollment in clinical trials and also for triage, because I think this is going to be really critical as we prepare for a second wave. So this is our JH Crown team. This is the registry team that I work with. So I thought I would stop there and lots to talk about, and I'm sure lots of experiences that we can share together.
Brian, thanks so much. There's a couple questions, and then I'm going to open it up to the panelists for their questions, comment on your presentation. Question from Dr. Seibold. Hello, I see that Black race is noted as a risk factor. In the Southwest, there seem to be reports of Hispanic and Native Americans as being risk factors for worse COVID disease, if not cytokine storm also. Could you comment?
Yeah, so I think we're beginning to understand that certainly there are a lot of factors that underlie risk. And so when we say that African Americans are at higher risk, when you look at certain populations, like in New York, for example, the amount of disease that we're seeing in the African American population is much higher than what you'd expect for their percentage of the population, and the number of deaths that are being reported are much higher than you would expect just based on the demographic distribution of different races. And that's also true in the Midwest for Native Americans. And we're actually in Baltimore over the last month, we now have over 30% of our inpatient cases are from the Hispanic community. And it's not clear there are many factors that are likely at play. I think certainly this epidemic has highlighted some of the inequities in our ability for different groups to access healthcare, the differential distribution of comorbidities that oftentimes are aligned with socioeconomic issues that this virus has highlighted. Could there be some genetic polymorphisms that might have, we know if you look at the cytokine response in individuals to this virus, there's a marked degree of heterogeneity that almost certainly is going to be linked to genetics, but also is probably linked to underlying comorbidities as well as what viruses you may have come into contact with in the past. So I think it's really, really complicated, but it certainly, I think, is a really important lens for us to recognize inequalities in both underlying comorbidities and socioeconomic status, but also access to care. Hey, Rick, I think you're on mute.
Thank you. Yeah, you'd think I'd have that figured out by now. One more question before I turn it over to the panelists for their questions, comments on your presentation. But as many of you who have been on these rounds before know, we have a really wide range of disciplines, expertise that attend these rounds. And we did get a question from, in the registration process, from what I assume would be from an EMS provider. What should EMS personnel know about cytokine storm?
Well, I think it's important just to recognize whenever you're seeing a patient in the field who, has a high fever, is dyspneic, maybe has hemodynamic instability, it certainly could be sepsis from a common bacterial infection, but I think in our current climate, you should probably be thinking, wow, this may not just be sepsis from a garden variety organism, this could be coronavirus. And I think, it's important to remember that, ideally we would always know kind of when someone's date of onset of symptoms were, but people access care at all different points in their disease illness for a number of different reasons. And so, if you get called for someone who has these features where they're breathing really, really fast, they're hypoxic, they're hypotensive, certainly think sepsis, but also I think consider that this could be the cytokine storm from COVID, and make sure that you're taking adequate precautions as you otherwise would.
Yeah, thanks, Brian. I'm going to open this up for questions, comment from panelists. And if you're on the screen, raise your hand and I'll call on you. And if not, I guess you got to just yell out and take yourself off mute. Paul.
So Brian, thank you. That was fantastic. I think we're obviously trying to all figure this out, and you guys are doing some amazing work. Do you have a sense for when some of the trials will start to be able to have preliminary data? Because I think, ultimately we're all searching for an answer, but it just takes time to recruit. And with thankfully some declining numbers, just curious if enrollment is being affected by that as well.
Yeah, no, I think we worry about that, right? We worry that since we don't yet have a great sense of who would be eligible for its trial, when we have fewer patients that are being admitted every day, and each trial has their own unique set of exclusion criteria, I think we've slowed down in terms of the number of patients who get enrolled in a clinical trial every day. We peaked at about 300 patients in our health system a day. To this morning, I think we were down to about 160. And obviously that fluctuates from day to day. A lot of the trials that I showed you are really early phase 2 trials that are sort of proof of concept. And then if it looks like there's a signal that would justify doing a much larger phase 3 trial. So I think we're still months away from knowing, at least for the therapies that I showed you, whether or not there's going to be a clear benefit to using some of these anti-IL-6 or anti-inflammatories. And I'm not sure. I know enrollment has been ongoing for about 3 weeks now for Act 2, which is the baricitinib on, or placebo on the background of remdesivir. So hopefully we'll have something from that. I think there are over 80, maybe even 100 centers that are enrolling in that arm. So hopefully that'll be something that'll come out in the next couple months.
Thanks, Brian. Other questions, comment from our panelists? And then I've got, there was a lot of questions that have come in, Brian. Let's see if I can get to some of them too. James or Vikram? All right, let's see here. One question, what is the difference between hyperinflammatory syndrome and viral sepsis and septic shock? Big question.
Yeah, so this is a really interesting idea, right? I think we're all looking for things that are unique about this virus and trying to understand, what's unique to COVID-19 and what may be something that's just part and parcel of developing a viral acute respiratory distress syndrome and inflammation secondary to it. And I think the short answer is we're not entirely sure, but if you look at the small studies that have been done prior to this in other forms of ARDS, when people have looked for it, IL-6 numbers are through the roof, right? So IL-6 is not a uniquely elevated cytokine in the setting of COVID-19. But we've never before considered using an anti-IL-6 therapy for patients with viral ARDS. And I think part of it may be simply that we have so many patients that we're seeing right now. We have a 24-bed medical intensive care unit, and that's been full with COVID patients for 2 months now. And we've had to open 5 other intensive care units for COVID-19. In a given month, we might have 2 or 3 patients who have ARDS in our ICU, right? But now we have 24 patients who have ARDS. And so the question becomes, how many of these observations that we're seeing are related to sort of recency bias and availability bias versus truly being different about COVID-19. And I think we're starting to get a sense that maybe some of the microvascular thrombosis that may be different than traditional forms of ARDS. But I think what we're seeing, this inflammatory response to this viral infection, is probably not unique to COVID. It probably happens. We've all had cases. Earlier this year, we had several young patients die from fulminant shock with influenza B. And it was probably a very similar situation to what we're seeing in just a higher number of patients with COVID-19. So I don't know if we're really going to be able to right now say that this is unique to COVID, or if it's just something that's happening at such a high prevalence that we're for the first time ever able to study it and do much more aggressive phenotypic isolation of cytokines and really kind of understand this inflammatory response at a much more granular level.
Thanks, Brian. Vikram, did you have a comment or question?
No, I just wanted to emphasize that Brian gave a fantastic talk and wanted to thank him for it. And I just wanted to emphasize also what Brian mentioned is that the TOCI, the convalescent plasma, all the stuff that we're using at the bedside really doesn't have a lot of evidence behind it yet. And while we hope that some therapeutic tool comes to fruition soon enough, right now, at least at Bellevue, we're using them either in a compassionate use or under the umbrella of a clinical trial.
Thanks, Vikram. Let's see.
Hey, Rick.
Yeah, James, got it. Go for it.
Yeah, sorry. Thanks. Brian, great presentation. I really enjoyed it. Very helpful. And this is a question for the entire group, and it is not intended to be, I'm not trying to be a smart ass, although Rick knows that's kind of my prototypical behavior. This is actually a legitimate question. We have had attempts to modulate and mitigate dysregulated or hyperinflammatory immune response for severe outcomes in sepsis, for other viral diseases where we know that this is an important mechanism for pathogenesis, dengue being an obvious one. And we have failed spectacularly each time. So why do we think that this is going to be different? What leads us to believe that we have better insight into the mechanisms of COVID pathophysiology that gives us optimism that any of these interventions will work? I completely support doing randomized clinical trials. I think that's hugely important, but I am not optimistic that any of these is going to show benefit, and I'm very skeptical of efforts to use these drugs outside of randomized clinical trials.
Well, I think, Jim, you just made the most important point, which is to say that I think we really need to try to resist using these therapies outside of clinical trials. I think the only way we're ever going to know if they work is if we do them inside of a clinical trial. And I think there's very good reason to believe that some of these therapies might, in fact, be harmful if used at the wrong time in the wrong patient. And so, I do share your skepticism that we're going to find a number of therapies that are going to work. But I think what might be different this time is that I think it's possible that the reason that most of the trials in ARDS have failed is that we haven't been able to phenotype patients quickly enough to get them enrolled and to understand who might benefit to certain therapies. And we have so many patients right now, and we have so many different ways of trying to phenotype these patients that it's possible that we might be able to find a therapy that works in a specific subset of patients if given at the right time. And so I think, I think it's probable that there's something that if we targeted it before he got intubated, before the cat was already out of the bag, there's something that might work. But the question is, are we going to be able to find that population and work quickly enough to show a benefit? But I definitely think we've lost a lot of ground in terms of using these therapies off label and just not knowing if they're going to work. And I think one of the things we're worried about, we've seen a lot of a higher incidence of fungal infections in our ICU, and that's been described in Spain and Italy as well. And you wonder how much of this is related to us altering the folks' immune systems versus this being a consequence of the lymphopenia that we know is being caused directly by the virus. So I think we need to be careful, but I'm hoping that with the number of patients we have and the ability to enroll patients very early, we might be able to have something that has a benefit.
Thanks, Brian. Other panelists, questions, comments? All right, hearing none at this point, let's go to the polling if we could, Echo. So for the multitaskers, if you could pay attention to the screen, we're going to do some poll questions, most of which are focused specifically on cytokine, but there are a few that are general related to ICUs. So yeah, give us a second to pull this up. Okay. So you will see in these questions, if you're, some of these are very specific to intensive care unit setting. So many of you may not be in the ICU setting. So there's this not applicable category that you can respond to, just so everybody gets a chance to provide some input. That would help a lot. So today, what % of patients in your ICUs have experienced cytokine storm? And it's the range 0, 1 to 25%, 26 to 50%, 51 to 75%, 76 to 99%, 100%, or not applicable. And hosts and panelists cannot vote. So another 15 seconds on that one, 10 seconds. It's a pretty straightforward one. Okay. All right, looks like 1 to 25% was the winner, and those that, yeah, in terms of numbers. All right, next. Compared to April 15th, and I just use that, okay, tax day, but it's about 6 weeks ago. My approach to cytokine storm in COVID-19 patients is the same, different, or not applicable. All right. Fascinating. It's kind of a split between same and different. All right, next. What source of information has been the most helpful in your assessment and care of cytokine storm? So it's a source of information that's been the most helpful. Fellow intensivists in my hospital, fellow intensivists in other hospitals, peer-reviewed papers, professional society, nationally or internationally promulgated recommendations, guidance, or protocols, public health. And like 15 seconds for that one. All right. Looks like the recommendations, guidance, protocols. 57% by a large percentage. Next. This is a much more general about sort of where we are with COVID-19 in ICUs. Today, what percentage of patients in your ICUs are COVID-19 patients? And I put ICUs as in, you know, there are multiple ICUs in many facilities. So collectively across your ICUs, what percent are COVID-19 patients? All right, let's see what happens here. About 48% is the, looks to be the highest percent there. Okay. Or I'm sorry, not 48%. 1 to 25% is the highest ranking of the choices. Next. That's much lower than it used to be, that's for sure. All right, in the past week, since May 26th, my ICU has experienced nursing staff shortages. Yes, no, or don't know. Okay. %20 said yes. All right, next. This one's physician staff shortages, I think. Yeah, the past week, since May 26th, my ICU has experienced physician staff shortages. Yes, no, or you don't know. Okay. %66% of you said no. All right, next. So this is related to ICU surge space, okay? So those of you that, you know, surged up with intensive care unit space, our ICU surge space is still open and staffed. Yes, no, or I don't know. Okay. Wow, it's a close to even split between yes and no. All right, next. Our organization has updated our response plans to include both COVID-19 and protests. Yes, no, in progress, or don't know. Okay. %28 said yes, 32% said no, 18% in progress. All right, thank you very much. That was great. That's great input. Appreciate that. I've got, what I'm gonna do is I've got a couple more questions that came in the QA section. Brian, I've got a couple more questions if you could like provide at least a little input on, that'd be helpful. And then I'll close this out by going around the table with our panelists, and then we'll finish up. So Brian, there was question about, are you enrolling patients with studies using hydroxychloroquine?
Yeah, so we actually just started enrollment in a hydroxychloroquine plus azithromycin trial. You know, and I think, you know, it's important to talk about this, because I think we lost a lot of time early on in the epidemic when everyone was sort of you know, hydroxychloroquine almost became standard of care across the country. And I know our hospital gave a lot of hydroxychloroquine early on as well. But the question is still unanswered. Does it have a role to play in certain subgroups of populations? And I think even the retrospective studies that have shown, sorry about that, shown a signal for risk, I think have not definitively answered the question. So we just started last week enrolling patients.
Another question was regarding high lactate levels, and you know, okay, septic shock, lactate, et cetera. But how are you using lactate levels, if at all?
Yeah, you know, I think it just depends on the patient. You know, by and large, I think the patients that we're seeing are not developing shock physiology. Many of the patients who go on vasopressors are doing so in the setting of high sedation requirements, sort of peri-intubation. But there certainly are a subset of patients who develop more classic shock, and you know, some of those patients probably have direct cardiac injury, which there might be a component of cardiogenic shock. Others might have more distributed physiology. So I think it's something that we will check in patients who have hemodynamic instability, but not necessarily a marker that we're sort of just checking in the absence of context.
Yeah, great. Then another question, could you comment on the potential role of IFN and IFN-related therapies in the treatment of cytokine storm?
Yeah, so you know, I think there's lots of potential cytokines that have been implicated in this dysregulated inflammatory state. So there are some folks who are trying to get trials up off the ground, looking at different combinations of interferons. You know, I think interferon and ribavirin have been previously tried in SARS, you know, a decade ago. It's unclear, again, you know, what the right population would be, how best to administer the interferon. There's lots of different interferons that you could potentially try to engage in this. So I have not seen any large trials showing benefit, but I've seen lots of theoretical models and some mouse models suggesting that there might be a role to play in interferon targeting.
Yeah, thanks. I read a review paper, I think it was in New England Journal just within the past couple of weeks, and the list of options for that seemed large. So let's see, the next question, and this I think actually is related to rounds we did to last week on pediatrics, a special session on pediatrics, where there was a discussion about fluid management that, and actually fluid management in the field of pediatric patients that were really sick. So anyway, here's the question that came across. In pre-hospital, in adults, if an adult has high fever, is hemodynamically unstable, hypotensive, should we be fluid bolusing as normal to stabilize, or use caution now? Because I've heard information that at least in peds that fluid bolusing might be dangerous. Is the adult the same? And I think I'm guessing, but it's a pretty reasonable assumption. This may go back to some of the conversation that was on the pediatric session last week. So yeah, it's basically approaching adults for somebody in shock. Yeah.
Yeah. Well, you know, I think if we go back to, it's important to remember what it is that we know about other diseases that cause ARDS, and to not automatically assume that this is going to be somehow different. I think in general, we, as pulmonologists, we like to talk about a dry lung being a happy lung, but at the same time, patients who have lung injury and also develop shock need fluid resuscitation. And I think many of our patients, you know, have high insensible losses with high respiratory rate, high fever. the anorexia in this illness is pretty profound. Patients will not have been able to eat for days at a time, perhaps, before they call the hospital. And so I think if someone's in shock in the field, I would not worry about giving them fluid. We know that, in early goal-directed therapy and sepsis, even in those, I know there's evolving controversies about how to fluid manage sepsis in general, but, patients who are likely to be intubated are going to get intubated early, regardless of what their early fluid management is. It's sort of down the road whether or not that fluid management will impact intubation. I think early on, I would err on the side of giving fluid to a patient who's clearly in shock. But later on is when I think you start to have to worry about, appropriately managing the fluid balance with the possibility of, pulmonary capillary leakage and the inflammatory state. But that's what I just said is by no means based in evidence about this disease, and I think would be reasonable to debate.
Oh, yeah, Brian, the question, when I read it, and then as you're answering, I think to myself that, in our history of diseases, one new disease, does it change every approach we should have ever had or will have in the future about diseases? And for this one, being really cautious about those dramatic changes, which you pointed out, like the need for the more research and so forth, I think is a really important thing to make sure, like, some of our principles just don't get thrown out on a whim, for sure. So anyway, editorial comment, obviously. Yes, Paul.
I just would agree definitely with what was just said, but I would draw a bit of a distinction in the pediatric and adult cases between acute COVID infection and what appears to be a syndrome of post-viral complication. And so we know that even in the MISC, the pediatric multisystem inflammatory disease, that probably is a set of conditions. It's probably not one thing, but those patients in particular, these post-infectious MISC patients, don't seem to do as well, at least in our anecdotal experience right now with fluid, different than acutely infected patients early in the course with COVID. So if that distinction helps.
Yeah, no, I totally understand.
And Paul, do you think that that's driven more by the potential for cardiac involvement in children?
Yeah, absolutely. I mean, in our experience so far, when we've done bedside echoes, we've seen dramatically decreased contractility. And so it's directly related to myocardial contractility. And,
stating the obvious, for those in the field trying to distinguish between the two, which is going to be a COVID complicated pediatric patients versus not. So really tough. And I think, to me, at least my personal opinion is real need to make sure you're in touch with your medical control people to help. So, yeah. Okay, so let's go around for the panelists before we wrap up. Make sure there's opportunity for any further comment, question. Vikram, I'm going to go to you first. So can you there you go. Thank you.
Thanks, Rick. Again, a great presentation and a discussion. Thank you, everybody. And I think my closing comment would be that while we hope that there is some therapeutic evidence behind therapeutics come quickly, I agree with James that historically we've been humbled, and supportive critical care is what is key in most of these patients.
Yeah, thanks, Vikram. Let's see, James?
I have nothing else to say. I'll rest my peace, Rick.
Oh, last shot here.
I'm good.
Okay, great. And so, Bruce, any questions before we you were reading these questions right along with me. Any questions from the group of questions or comment?
Well, one last one that Anthony Jackson asked, is the use of anticoagulants still recommended during cytokine storm? Might be one to see if Brian or others.
Yeah, I think this is still controversial and needs to be studied, right? I mean, I think many of us have changed our practice in terms of approach to prophylaxis for DVT and thrombotic disease. I am very worried about moving towards some, laboratory marker, some other set of clinical parameters outside of diagnosing a true clot that, would allow us to say, all right, this person in this syndrome needs to get full dose anticoagulation, because remember, there's always a risk. And I think we're going to find out, we need to find out if that risk of bleeding in those patients who we might consider at high risk of thrombotic complications may in fact be higher than the microvascular thrombi that we will likely be unable to diagnose while they're still alive. And so I really do worry about that. And so we have not, we really have required in our practice, confirmation of a DVT or a PE or unexplained right heart failure with no other explanation as something that would drive us to use anticoagulation. Simply seeing a high D-dimer and respiratory failure, I think I would be really cautious about full dose anticoagulation without a clear indication.
Great, thanks, Brian.
Yeah, and Brian, before we close out, I always make sure the speaker gets the last word. So any final comments before we close out?
Well, I'd just like to say thank you to everyone for being here today, and for you guys for putting this on and inviting me to be a part of it, and just, reminding everyone that we're all in this together, and that we're going to find out the answers to some of these questions only if we work together and really trust the process of trying to get as many patients as we possibly can enrolled in high quality clinical trials to really come up with an answer to these questions.
Yeah, thank you. Thanks very much, Brian, especially reinforcing the need for the trials that will, without them, we're not going to have answers. So with that, let's see. Bruce, any final words before we close out?
Just thank you, Brian. Thanks to the panelists. Thanks to the over 400 participants that joined us. And please take advantage of the CME opportunity and give us your feedback. And be well and have a good week.
Yeah, thank you. And thanks to our participants. Thanks for participating in the QA, the chat, which has been extraordinarily robust. And participating in the polling. Fascinating to watch that as our experience with the disease and our new challenges in our nation are evolving. For our panelists, thanks for keeping keep coming back. We appreciate that very much. And Brian, you took on like not the easiest topic in the universe. Wow. Yeah, thanks for walking us through the challenges and sharing your experience and the data you've gotten so far with us. And yeah, let's all keep keeping on and stay safe and be well. Bye.